Hello, friends. In my class series in gynecological malignancies, the first topic which I would be covering is on a common cancer, which is very common in women, and yet which is preventable by vaccination and by early detection. Yes, it is cervical cancer. I would be dealing with important highlights, that is a bird's eye view, in two parts. In this first part on cervical cancer, I would be covering the incidence, pathogenesis, diagnosis, prevention, and staging. These are salient points which would be helpful for all clinicians. Globally, if you see, cervical cancer continues to be one of the most common cancers among females. It is the fourth after breast, colorectal, and lung cancer. In Globocon 2020, it was seen that there were 604,000 new cases of cervical cancer and deaths, 342,000 deaths annually. But majority of new cases and deaths occur in low and middle income countries where it is the third common cancer among women. If you look at Indian data, cervical cancer is the most common cancer in Indian women, and its incidence has considerably increased. Over 80% of cervical cancer women present with advanced stage, and annually around 80,000 deaths have been reported. India being the second most populous country in the world, it accounts for 27% of the total cervical cancer deaths. This disproportionately high burden of cervical cancer, which is seen in India and other developing countries, is because of lack of screening, which would help in detection of precancerous stage and early cancerous stage and subsequent management. So these points would be covered: details of anatomy, etiopathogenesis, the diagnostic workup which is required, preventive strategies which are very important, and staging. If you look at the anatomy, cervix is the lowermost part of the uterus. It is a cylindrical structure consisting of stroma and epithelium. So it has two parts: the ectocervix, the part which projects into the vagina, which has squamous epithelium as its lining. The endocervical canal, which extends from internal os to external os, has columnar epithelium. Most cases of cervical carcinoma originate from ecto or endocervical mucosa in the transformation zone, that is the area between the old and new squamocolumnar junction. As you can see in this picture, at birth, the ratio between uterus and cervix is 0.5:1. On puberty, it becomes 1:1, and then subsequently in adulthood, 1:0.5. You can see the proportion being changed. So there is a transformation from squamous epithelium to endocervical epithelium, and then it again becomes squamous. So these changes are labeled as old squamocolumnar junction and new squamocolumnar junction. The area between old and new squamocolumnar junction is the transformation zone. Because of these constant changes, cells being changed, there is metaplasia, and because of persistence of HPV infection, that may result in development of malignancy over years. The ability to easily visualize and sample the cervix contributed to very early understanding of this natural history of cervical cancer and the fact that it is because of HPV infection. Cervix being projected into the vagina, it needs little or no anesthesia for treatment, and precancerous stages can be easily treated by freezing or burning. And this is how simple outpatient techniques of screening and prevention have developed. Going to the etiopathogenesis or natural history of disease, persistent HPV infection now has been labeled the most important cause. In countries where there is high incidence of cancer cervix, the prevalence of HPV infection is 10 to 20%, while in countries with low incidence of cancer cervix, the prevalence is 5 to 10%. Immunization against HPV thus will prevent persistent infection and will be helpful in preventing cancer. If you look at the natural history, squamous cell carcinoma occurs at the squamocolumnar junction or in the area of transformation zone. there is a stepwise progression from normal to higher levels of dysplasia. So what happens initially is development of abnormal cells or dysplasia. Dysplasia could be of three types, CIN1, 2, and 3, depending on the degree of involvement of the epithelium. Lower one-third, if there are abnormal cells, it is CIN1, middle two-thirds, CIN2, and whole of the epithelium has abnormal cells, as you can see in this picture, it is CIN3. If it breaches the barrier, then it becomes CIS, cervical carcinoma in situ. In CIN1, 60% have regression of the lesion, while in CIN2, 40% regress. So because it is due to persistent HPV infection, once the infection subsides, they may, over a period of 1 to 2 years, they may regress and normal epithelium may develop. However, higher levels of dysplasia progress to cancer, and this progression from pre-invasive stage to cancer takes 10 to 20 years. And this is the reason why screening methods are useful in early identification, and early treatment of pre-invasive lesions would help in preventing cancer cervix. These are the various risk factors in addition to persistent HPV infection. If these risk factors are present, then it predisposes the woman to development of cancer. Multiple sexual partners, greater number of sexual partners, and greater chance of acquiring HPV. Early sexual activity, multiparity, too frequent and early childbearing, the presence of other sexually transmitted infections, and immunocompromised women with a weak immune system. Smoking has been seen to be associated with squamous cell cancer. Exposure to a miscarriage prevention drug, that is DES, diethylstilbestrol, which was being used in early 1950s. Now it is no longer being used, but it was responsible for a certain type of cervical cancer called clear cell adenocarcinoma. Well, persistent HPV infection, a prior history of HPV infection also is a risk factor, and a family history of cervical cancer. Then spread. Spread may occur by three ways: direct extension, by lymphatics, and by the hematogenous route. It may extend directly into the parametrium, uterus, and adjacent organs like bladder and rectum. That is local extension. Cancer also spreads along lymphatic channels to regional lymph nodes. So initially, it goes in a stepwise manner. Initially, obturator, then external iliac, internal iliac, and then common iliac and paraortic nodes are involved. Distant metastasis has been seen as in stage 4 to lungs, liver, and skeleton by the hematogenous route, but is a late phenomena. You can see the lymphatic spread in this picture. Cervical lymphatics drain into three dominant lymphatic trunks: the lateral trunk, the posterior trunk, and the anterior trunk. However, it occurs in a stepwise fashion successively from one portion to another. So initially obturator lymph nodes, which then drain into external iliac, common iliac, and subsequently paraortic lymph nodes. If you look at the symptoms, many women may be asymptomatic in the initial stages. In cases of precancerous lesions, women do have abnormal vaginal discharge. So this is why LBC, liquid-based cytology, or Pap smear for all women in the reproductive age group after the age of 35 is important. The symptoms that may be general symptoms like abnormal vaginal bleeding in 80%, excessive vaginal discharge, and symptoms of pelvic organ compression or extension or invasion in advanced stages. Early disease symptoms include abnormal vaginal bleeding, dyspareunia, and pelvic pain. Late disease symptoms may be sciatic pain because of lumbosacral plexus involvement and compression of that area by the tumor. Lower extremity edema because there is extensive pelvic lymph node obstruction, lymphatic obstruction, and hydronephrosis because the ureters are nearby. There could be ureteric obstruction. Basically, the symptoms would be pelvic pain, urinary or rectal symptoms like bowel or urinary obstruction, and at times it may erode through and may cause vesicovaginal or rectovaginal fistula formation. Now, pathology, WHO recognizes three categories. Mainly, it is squamous cell carcinoma developing from the ectocervix in 70 to 80% cases, but it could be adenocarcinoma in 10 to 15%. Other epithelial tumors have also been seen, like neuroendocrine tumors and undifferentiated cancer. Now, the growth could be exophytic, means it is growing out of the surface, or it could be endophytic in the form of an ulcer, stromal infiltration with minimal surface growth. Coming to the diagnostic workup, before labeling a patient to have cervical cancer, a tissue diagnosis is essential. Initial diagnosis and initial stages can be made by a pap smear or liquid-based cytology, then has to be confirmed by a biopsy. Even a normal pap smear in presence of visible abnormality does not exclude tumor, and direct visualization is important. Biopsy, endocervical curettage, and if negative, at times cold knife conization must be done to identify the condition. Other lab tests which are important are a CBC, liver function test, kidney function test, and a coagulation profile. Viral markers in the form of HPV DNA may be required, and urine analysis is important because it may erode into the bladder. Other workup, other investigations, chest X-ray to rule out metastasis, CT or MRI of abdomen and pelvis to identify its spread, and at times a PET scan may be required. Sometimes to confirm diagnosis, we may require examination under anesthesia, especially to do the clinical staging. If you suspect it has invaded into the bladder or rectum and it is not seen on a scan, then cystoscopy or proctoscopy may be required. At times, urethral stent placement could be indicated. There are two main diagnostic modalities to identify spread and its location, those are CT scan and MRI. Let us see in which patients a CT would be helpful. CT is equally effective for evaluation of extrauterine spread of the disease. A significant number of clinicians prefer CT evaluation for cancer patients due to its wide availability. However, its accuracy for overall cervical cancer staging ranges from 32 to 80%. It cannot discriminate between normal cervical stroma and cancerous tissue. It performs poorly, and therefore, in assessing local spread with lower than 58% positive predictive value for detection of early parametrial invasion. However, staging with CT is limited to patients who have clinical evidence of advanced disease or who have certain contraindications to MRI. So if you want to identify advanced disease and beyond local spread, then CT would be helpful. For an MRI scan, this is the preferred imaging modality for evaluating local extent of cervical cancer due to its high contrast resolution, which enables differentiation between cancerous and normal tissues. So a CT was unable to differentiate, but here an MRI is useful in identifying even minimal local spread. It is primarily used for evaluation of tumor morphology and local extent. It accurately evaluates tumor features with significant prognostic value, like we can identify the size of the tumor, the presence of endocervical growth, parametrial infiltration, and infiltration up to the pelvic side wall, which would be helpful in the staging, and adjacent organ involvement. MRI accuracy for determining tumor stage is 75 to 96%. So it would be helpful in identifying whether the disease is operable or whether it is advanced. Clinical staging of cervical cancer and assessment of important prognostic factors significantly improves when MRI information is added to the clinical data. So after an examination, the patient must be evaluated by an MRI if possible. It helps in identifying surgical candidates among patients with cervical cancer because of its high negative predictive value, 94 to 100% for parametrial involvement. Also, when findings of clinical examination are unclear or when it cannot be performed due to patient obesity or discomfort, a MRI may be used for treatment planning. Then third modality is a PET scan. It is usually used for identifying recurrence or metastatic disease. PET-CT allows high diagnostic performance for detection of tumor relapse and metastatic lymph nodes. It may help detect small FDG avid tumors, which are as less as 7 mm. Then there's the concept of hybrid imaging, either CT with PET or MRI with PET. These are superior to conventional cross-sectional techniques for identifying metastatic lymph nodes with excellent diagnostic accuracy ranging from 85 to 99%. So once you identify metastatic lymph nodes, you would need to change the modality of treatment. And this is how they prove to be useful. However, its role in initial evaluation of cervical cancer has not been established. Accuracy of PET-CT for local staging of cervical cancer is moderate, 53%. PET-MRI may be promising for assessment of primary tumor with a sensitivity and specificity values over 90%. Now coming to the most important aspect, prevention. How could you prevent cervical cancer? It is said an ounce of prevention is better than a pound of cure. Prevention could be of two types: primary prevention by vaccination, by HPV vaccine, and secondary prevention by early detection and treatment of precancerous lesions before they turn into cancer. HPV vaccination was launched in 2006. There are 3 prophylactic HPV vaccines which are currently available for use in females and males from the age of 9 years for prevention of pre-malignant lesions and cancers affecting not only the cervix but vulva, vagina, and anus, which may be caused by various high-risk HPV types. The bivalent vaccine targets HPV 16-18, quadrivalent 6-11 in addition to 16-18 HPV. Recently, there is a nonavalent vaccine which targets HPV types 31, 33, 45, 52, and 58 in addition to HPV 6-11, 16, and 18. In addition to the last 2 vaccines, they target enogenital warts which are caused by HPV 6 and 11. These all vaccines are recombinant vaccines composed of virus-like particles. They're not infectious because they do not contain viral DNA. For girls and boys 9 to 14 years, 2-dose schedule, 0.5 ml at 0 and 6 to 12 months. That is, the second dose to be given 6 to 12 months after the first dose is recommended. But if you are vaccinating after the age of 15 or in older and immunocompromised patients, irrespective of age, 3 doses are recommended: 0, 1 to 2, and 6 months. WHO has reviewed the latest data and concluded that there is no safety concern regarding HPV vaccines. Then, secondary prevention by early detection. Cervical cancer is a rare long-term outcome of persistent infection of the lower genital tract by one of the 15 high-risk HPV types, which are termed necessary for the cause of cervical cancer. Persistent HPV infection denotes the presence of same type specific HPV DNA on repeated sampling after 6 to 12 months. It has been seen that women of reproductive age group, they have 80% have HPV in their smears, which means 80% are infected with HPV. Now, if this infection remains persistent for 12 months, then it is considered to be a cause for the development of pre-invasive and invasive lesions. The same thing, more than 80% of women followed over time will acquire at least one high-risk HPV infection, which shows its ubiquitous nature and ease of transmission. 1/10 of all infections become persistent, and these women could develop cervical precancerous lesions initially. Of the estimated 604,000 new cervical cancer cases annually worldwide, HPV 16 and 18 account for majority of cases, 71%. Other types 31, 33, 45, 52, and 58 account for the remaining 19% cases. It is well documented that nearly 90% of incident HPV infections are cleared within a period of 2 years from acquisition of infection and persistent only in 10% of women. So this is how it develops. CIN1, there is a regression rate of 60% and only 1% progress to cervical cancer in a period of 1 to 20 years. However, CIN2, 40% regress, 5% progress, but if there is CIN3, regression rate is 33% and 10 to 20% may progress to invasive cancer. Screening is the most important strategy in global elimination of cervical cancer. HPV vaccination aims to prevent cervical neoplasia by preventing infection, but screening aims to detect prevalent cervical precancerous lesions such as high-grade CIN and adenocarcinoma in situ early and effectively treat them to prevent invasive cancer and decrease cervical cancer mortality rates. The various screening strategies include a conventional pap smear. Then recently, liquid-based cytology and HPV testing have been proved to be useful and very effective. And in low and middle income countries, the initial strategy see and treat and visual inspection with acetic acid is useful. Visual inspection with acetic acid screening involves detection of an acetowhite lesions on cervix after application of 3 to 5% freshly prepared acetic acid. In view of its feasibility, it has been widely implemented in opportunistic settings of many low-income countries and even in our country. A single visit approach for screening with rapid diagnosis and treatment improves coverage, eliminates follow-up visits, and improves cost efficiency in low resource settings, management of screen, and then subsequent, if they are positive, their management, that is triaging and treating, single visit approach. The various treatment options include cryotherapy, thermal ablation, loop electrosurgical excision procedures for CIN1 lesions, and treatment for prevalent cervical cancers which have been detected by screening. If you look at these FIDGO guidelines, in good resource settings, the various modalities include HPV testing, primary HPV testing, or co-testing, that is an HPV test along with a cytology, and VIA. In limited resource setting, however, VIA is very useful. The targeted age group is 25 to 65. However, in a limited resource setting, it is 30 to 65. The age to start is 25 and VIA at 30. Frequency, primary HPV testing or co-testing every 5 years, and cytology is indicated every 3 years. However, if you do a VIA in low resource setting every 5 years, so that the woman gets tested at least 1 to 3 times in a lifetime. Then these are the screening tools which we had discussed, the triage tools, cytology, plus newer modalities like an HPV test, management options, and single visit approach is very important, see and treat. So once a VIA has been done, you identify the lesion, you can take a biopsy, or you thermoablate that lesion, cryotherapy or thermal ablation. That will help in elimination of that precancerous lesion. And of course, follow-up is very important. In limited resource setting, if colposcopy is available, it can be done after a VIA. A biopsy can be taken. Treatment with cryotherapy, LEAP, conization, or thermoablation. And then the screen, see, and treat approach is very useful. The age to stop screening is 65. And those women who had no prior screening should undergo test once at 65 years, and if negative, they should exit screening. Follow-up, HPV testing or cytology, the interval for follow-up, if it is found to be positive, is 12 months. VIA, again, if positive, after 12 months. Screening following abnormal reports, CIN2 or above, irrespective of method of treatment, screening should be for 20 years. Those women who have been hysterectomized following hysterectomy and in which cervix was removed for benign causes, there is no need for screening unless there is a history of previous CIN lesion. Absence of cervix must be confirmed by clinical records or examination. If indications for hysterectomy are unclear, screening may be performed at clinician's discretion. Now, follow-up in women with CIN in hysterectomy histopathology report need to be screened with HPV at 6 months and 18 months. Women who are immunocompromised, screening should start within 1 year of initiation of sexual activity. It could be done through HPV testing, co-testing, cytology, or even VIA, and should be repeated every 2 to 3 years. Now coming to the last aspect, that is staging, and staging by FIGO classification 2018. Cervix was the first organ to be assigned a clinical staging by FIGO in 1958. Subsequently, the TNM staging followed, which has been used for the purpose of documenting nodal and metastatic disease status. In 2018, FIGO Gynecologic Oncology Committee revised staging to allow option of clinical, radiological, or pathologic findings as available to assign a stage. So initially it was only clinical staging based on examination under anesthesia findings. But now with MRI and CT and pathological findings, a stage can be easily assigned. So there are 4 stages, like all other cancers. In stage 1, the carcinoma is strictly confined to the cervix. Extension to the uterine body or corpus should be disregarded. So it is only limited to the cervix. Stage 1 is divided into stage 1A, stage 1B. Stage 1 is invasive cancer that can only be diagnosed by microscopy, and minimum depth of invasion is equal to or less than 5 mm. So it is a microscopic diagnosis. Stage A1, measured stromal invasion is less than or equal to 3 mm, and stage A2, measured stromal invasion is more than 3 but less than 5 in depth. Stage 1B is invasive carcinoma with measured depth of invasion greater than 5 mm. So greater than that was there in 1A. But the lesion is limited to cervix with size measured by maximum tumor diameter. So in stage 1B, it is further divided to B1, B2, and B3. B1, invasive carcinoma, more than 5 mm depth of stromal invasion, but less than 2 centimeters in greatest dimension. B2, more than 2 and less than 4 centimeters in greatest dimension. And B3, invasive carcinoma, more than 4 centimeters in greatest dimension. So the depth of invasion and the diameter, the greatest dimension is considered in stage 1B. As you can see in this picture, in 1A1 and 1A2, it is microscopic and the depth of invasion is limited to 5 mm. But in 1B2, it is macroscopic. You can see the tumor. In addition to the depth of stromal invasion, the dimension of tumor becomes important. Less than 2, then it is B1. 2 mm to 4 centimeters, it is B2. And if it is more than 4 centimeters, it is B3. Coming to the second stage, the carcinoma invades beyond the uterus but has not entered into the lower vagina or up to the pelvic wall. Further, 2 is divided into A and B depending on the site where it has spread. Involvement limited to upper 2/3 of vagina without parametrial involvement. So only the vagina is involved. If it is less than 4 centimeters in greatest dimension, it is 2A1. If it is more than 4 centimeters, then it is 2A2. But if it has gone up to the parametrium, then it is 1B with parametrial involvement, but parametrial involvement not up to the pelvic wall. So as you can see, stage 2A1 and A2 are limited to the vagina and less than 4 centimeters, more than 4. In stage 2B, there is parametrial involvement, but it has not gone up to the pelvic wall. Now coming to stage 3. Here, carcinoma involves the lower third of vagina and extends to the pelvic wall or causes hydronephrosis or non-functioning kidney or involves pelvic or para-aortic lymph nodes. So it has spread beyond. In 3A, It further has been divided into A and B and C depending where it has spread. 3A, it involves a lower third of vagina, but there is no extension to the pelvic wall. If it has extended beyond into the parametrium and up to the pelvic wall, if it extends into the parametrium, naturally the ureters are involved, so there could be hydronephrosis, non-functioning kidney, unless this kidney problem is due to any other cause. So if it has involved up to the pelvic wall, then it is 3B. 3C is involvement of pelvic paraortic lymph nodes, including micrometastasis, irrespective of tumor size and extent. So if nodes have been identified in an MRI scan, then it is definitely stage 3C. 3C1 is pelvic lymph node metastasis only, and 3C2 is paraortic lymph node metastasis. So 3A, lower third of vagina up to the lower third, 3B up to the pelvic wall, and 3C includes involvement of the lymph nodes. Stage 4 means it has gone beyond the limits and it has metastasized, it has gone beyond the pelvis and has metastasized to other organs. Carcinoma has extended beyond the true pelvis or has involved, could be biopsy proven, the mucosa of bladder. Bullous edema as such does not permit the case to be allotted to stage 4. So edema of the bladder is not included, but if it has been proved through biopsy that bladder involvement is there, then it becomes stage 4. Stage 4A and 4B. 4A, spread of growth to adjacent organs like bladder, rectum, etc. Stage 4B, spread to other distant organs. So 4A, spread to adjacent organs, bladder, distant organs means liver, lungs, etc. So this was all about part 1 of the bird's eye view on cancer cervix. Part 2 is to be continued. Feel free to ask any questions and please do subscribe to my channel. Thank you.